In addition to a run-through of things that you may be seeing in clinic or in the hospital, I'd like to go over treatment options and some clinical pearls, with the only disclosure being that we have a number of different ways of treating things in dermatology, and I will be presenting the evidence-based treatment options that we have available with a focus on what I actually do in clinic. So it has a little bit of my bias on it, but still all backed by evidence, as well as some updates and newer classification schemes that you might be seeing. So this first patient presents to your office, and I think you have all seen these lesions before. We have a mix of erythematous papules and a few pustules, and so you recognize this as acne. Now, the sine qua non of acne and what helps to distinguish it from rosacea is the presence of the comedone. And there are two different types of comedones, or clogged pores. We have open comedones, as evidenced here, also known as blackheads, and we have closed comedones, as evidenced here, or whiteheads. And in both scenarios, you are looking at an occlusion of the follicular unit that results in the buildup of dead skin and oil. In the case of the open comedone, that buildup is open to air, and so the contents oxidize and turn black. Whereas with the closed comedone, you have a layer of epidermis overlying, and therefore the contents stay white. What these lesions indicate is that you are dealing with a process in the acne family. Now, the most severe version would be nodulocystic acne, as evidenced here, showing a number of deep-seated papules and pustules, a larger cystic type or nodular type lesion, most often healing with scarring. But all forms of acne really begin with a disorder of the follicular unit that leads to the formation of the comedone. There are subtypes of acne that we see more rarely, particularly in young adult men, where there's extensive involvement of the face, chest, and back. This is more of an acne fulminans picture, extensive scarring, sometimes draining sinuses. You may also see systemic symptoms, fever, bony pain, etc. These patients will sometimes even present to the emergency department. And so treating them rapidly and getting control of the inflammation is quite helpful. Usually these individuals require a combination of prednisone and isotretinoin. And so this is sort of beyond the scope of what we'll be covering today, but good to know about in case you do see these individuals. They should be assessed early. In our approach to acne and its treatment, it's really helpful to understand the pathogenesis. And I go through this as best I can with patients simply because it allows for, I think, a greater degree of adherence to a sometimes complicated regimen. All forms of acne begin with hormonal stimulation of the sebaceous lobule. This occurs most of the time during adolescence or pre-adolescence, and we see a buildup then of oil and a stickiness to our keratinocytes so that they start to occlude the follicular opening. This is what gives you that comedone, either open or closed. It also creates an anaerobic environment that allows for the overgrowth of Propionum bacterium acnes, the main bacterial organism involved in the pathogenesis of acne. As this anaerobe really enjoys the environment that's been created and feeds off of the contents of this follicular unit, you'll see that it begins to replicate, eventually causing dilation of the pore to the point where you get pore rupture. The contents of that pore are released, and the body recognizes this as a foreign body and therefore mounts a response to that, walling off the contents with an immune reaction and then pushing it out of the skin in the form of a papule or a pustule. And that's where we end up here. Now, in individuals who are prone to having bad acne from a genetic perspective, or in general are predisposed to other inflammatory conditions, you may see a really exuberant response to this step in the pathogenesis. And that's what takes you from a papulopustular or a moderate inflammatory acne into more of a nodulocystic process, which is really marked by significant scarring. So when we see our comedone, the very first step is to approach this with a retinoid. And usually when the comedones are in isolation, a topical retinoid is sufficient. And I start all of my patients on a retinoid because no matter what form we're working with, there should be some comedonal component. And so the three types of retinoids that we utilize are tazarotene, tretinoin, and adapalene. And they're listed in order of greatest efficacy to least efficacy, but also greatest risk of irritation to least risk of irritation. And as you can see, they come in a number of different formulations and concentrations. In general, I tend to start with tretinoin 0.025% cream, as it is sort of in the middle, and patients can build up and increase concentration or change formulation based on how well they tolerate the medication. But we want to counsel to start really with a small amount, a pea-sized drop for the entire face, starting every other night for the first 2 weeks and then increasing to nightly once the medication is well tolerated. And this is because the main side effect is really dryness and irritation, flaking, and especially in the teenage population, this will limit your patient's ability to adhere to the regimen. If patients are unable to tolerate that increase to nightly, then I'll have them stay with every other night, or potentially even dilute the medication with a moisturizer, or I'll downgrade them again. There are combination products that theoretically would increase your adherence because they allow patients to just apply a topical medication once a day. Unfortunately, the combination products that exist for retinoids usually involve a benzoyl peroxide, and so I'm always concerned that we're taking two potentially irritating things and combining their irritant potential, and so I tend to stay away from the combination products, but they are out there. Once we've gone beyond the comedonal component, you can see we've developed papules and tiny pustules. We're looking at more of a mild inflammatory acne. Now, if you have a great density of these lesions, or if you notice that your patient is starting to heal with any degree of scarring, these little tiny ice pick scars or larger atrophic scars, that would be more indicative of a moderate or even severe evolving form of acne. And what we're looking at with the mild form is really this third step here, where you're getting just barely a little bit of an inflammatory reaction. And in this case, we tend to use, often in addition to our nightly retinoids, an antibacterial acne preparation. Usually these are harnessing both antibacterial and anti-inflammatory properties, and we tend to stick to benzoyl peroxide, clindamycin, and erythromycin. These can be used once or twice daily, and just like with our retinoids, you can see that they come in a variety of different formulations. I will often prescribe the pledgets, which are just wipes. It seems like it's very popular with the teenage population. They'll just wipe and toss. But certainly if you have someone who's dry, they may benefit from a lotion. Someone who tends to complain of oilier skin may tolerate an alcohol-based gel better. So certainly it allows you for a degree of flexibility. And what I'll do is really prescribe a topical antibiotic in the morning and then use the retinoid at night to simplify the regimen. Now, just like with our retinoids, there are combination products that combine benzoyl peroxide with an antibiotic. In this case, there actually may be some value to this, because not only are you simplifying the regimen, but you're decreasing the risk of resistance by adding the benzoyl peroxide. And with erythromycin, we're seeing quite a bit of a resistance, and so this can be quite helpful. Benzaclin and Duac are two that combine benzoyl peroxide with clindamycin, whereas benzamycin is benzoyl peroxide plus erythromycin. This may be a little bit difficult because this particular agent needs to be refrigerated, and so it requires an additional step for someone to A, remember to use the medication, and then B, go into the kitchen and pull it out of the fridge. So may not work for everyone, but increased efficacy, decreased resistance. You can utilize benzoyl peroxide in isolation, and so certainly you can prescribe a topical antibiotic by itself and then have the patient use the benzoyl peroxide as a face wash. Most studies suggest that using it as a wash where you leave it in contact with the skin for 20 seconds and then rinse off allows for the efficacy that you would need. Now, all benzoyl peroxides, if left on the skin and if they come in contact with fabric, will potentially bleach dark fabrics, and so I also counsel to be careful with dark towels, favorite t-shirts, pillowcases, etc. Either make sure you've really rinsed it off well, put it on after you've gotten dressed, or switch to white fabrics. Once we've transitioned from mild acne into a greater density of lesions, deeper seated lesions, painful lesions, scarring lesions, then we're starting to think more about moderate to severe acne. And for this, we really want to harness a systemic agent, and we utilize, as the cornerstone of our therapy, the tetracycline family of antibiotics. We use them both for their antibacterial properties, but also because they are really very good at being anti-inflammatory. Coupled with a decreased risk of generating resistance with chronic use, these become really the agents of choice. And while we've used tetracycline quite a bit in the past, we've really moved more into doxycycline and minocycline, and we're targeting that last big inflammatory step. Part of the reason why tetracycline doesn't work is it's not always well tolerated, but also because you really would probably need to take it 3 times a day to get a reasonable amount of efficacy, whereas minocycline and doxycycline are more long-acting. BID use is sufficient. In general, minocycline works better than doxycycline, and so patients who come to me having failed doxy, I will often trial them on minocycline, and it's thought that this is because you get better sebaceous penetration with the minocycline. Now, with all of your tetracyclines, we do think about some particular side effects, and I will counsel patients about the risk of vaginal candidiasis, photosensitivity, more rarely pseudotumor cerebri, and then some other more idiosyncratic reactions. I have to say these occur with low frequency, except for photosensitivity, where doxycycline is really our major concern. These are fairly severe burns that patients will get, and so you can also just not use them during the spring and summer months and go with minocycline instead. GI upset is another big issue, and so taking with food or spaced appropriately may be more helpful. One of the more rare but important to know side effects of minocycline is minocycline-induced pigmentation, where you will actually see blue-gray deposition of pigment, predominantly in scars. And in our case, we're looking mostly at acne scars. And so this young lady was started on minocycline, did beautifully. This is her 6 weeks after initiation. You can see that every little macule that she has here was once a large, deep-seated inflammatory papule. She has one scar that resulted a number of little atrophic lesions, but everything's really settled down nicely. Unfortunately, on follow-up, and you do need to follow these people up because they can be subtle and they won't necessarily see it, you can see she's developed just the most subtle blue-gray discoloration, very strikingly different from the red-purple of what a normal resolving scar or inflammatory lesion will look like. So if you catch this early and you stop the medication, it self-resolves for the most part. If patients stay on the medication long-term, this can be more difficult to get rid of. In addition to the scar type of pigmentation, you may see solar distributed pigmentation. You can see shins as a very common site of involvement, mucosal surfaces as well, tongue, and so I will warn people about this and I will examine them for it when they come in for follow-up. Quite rare, usually after long-term use, but is possible and so important to check for it. This young woman here clearly has severe acne, nodulocystic, scarring. Someone like this, you could certainly try minocycline, but I would anticipate that she's going to need a course of isotretinoin, and so probably I would proceed straight to that. With the now government regulation through the iPledge system, it's becoming more onerous to prescribe this medication, and so usually at this point I recommend referring to dermatology, as we have the infrastructure and the nurses who are trained to manage the idiosyncrasies of the program. However, another subtype that we're seeing more and more of, particularly in younger adults, 25 years of age and older, is a hormonal version of acne that affects the lower face, jawline, and neck. These tend to be fewer lesions. They are more deep-seated. They can be tender. They last longer. And this is a process that you may see flaring before menses. And so you want to use an agent that's going to target that hormonal component. And the two big ones that we use are birth control pills and spironolactone. And now we're back in the beginning looking at the hormonal stimulation of the sebaceous lobule. The FDA has helped us quite a bit now with this and has approved the use of certain birth controls for acne. And this is important because some formulations actually may make acne worse, but we know that these 5 listed here in their brand names as they were approved are FDA approved. However, the generics are just as good. So we're going to move on now to lesions that may appear in your clinic, usually in the newborn period. And so these individuals may present at birth, or they may present at the well baby visit, but the 4 main lesions that you may be presented with in clinic are juvenile xanthogranuloma, nevus sebaceous, epidermal nevus, and the mastocytomas. Juvenile xanthogranulomas are present either at birth or arise in the first 6 months, and you will see a very nice ovoid, smooth-topped papule, most often on the head and neck region, but it can be on the trunk or mucosal surfaces as well. They have a quite characteristic orangey yellow color to them for the most part, as evidenced here. However, you may see an orangey brown version as well. Rarely they're multiple. When you have multiple lesions or they're particularly large, we will send to ophthalmology because rarely there can be an association with ocular issues, and so we will have this assessed. But for the most part, these lesions, when they're small and in isolation, tend to resolve by age 2 or 3 spontaneously, and they don't usually leave any scarring. Nevus sebaceous is another lesion that is usually present at birth. You may look at it and think that it is a area of resolved cutis aplasia because it will start out often very, very smooth and flat as just a circular area of alopecia. If you take a light and you shine it on the side of the lesion, it will often cast just a very subtle shadow, and that may help to distinguish a flat or atrophic lesion like what we would think about with cutis aplasia from an actual growth like a nevus sebaceous. Over time, these will thicken. They do also favor the head and neck face region like the juvenile xanthogranulomas. These we now tend to watch. The main reason for removal is cosmesis. There is a small risk of transformation, usually after adolescence, of these lesions into majority benign lesions like trichoblastomas or syringocystadenoma papilliferum, but a very, very small fraction, usually after adolescence or into adulthood, can convert into basal cell carcinomas, in which case we would excise them just like we would excise a basal cell carcinoma in an adult. And so prophylactic excision we really don't do anymore. The sort of cousin of a nevus sebaceous is an epidermal nevus. It will also have a little bit of perhaps a mammillated surface, but usually hyperpigmented, often following Blaschko's lines or those embryonic migration lines, also present at birth or in early childhood, but they can become more pronounced and extensive with time. And as a result, we tend to recommend delaying any treatment until the full extent has been delineated. A number of different treatment options have been suggested: cryotherapy, dermabrasion, electrodesiccation, et cetera, but they certainly can be left alone. If they are extensive and very, very large, there can be some associations with underlying neurological issues and genetic issues. However, the majority will present like this: small, isolated, and asymptomatic. Cutaneous mastocytomas are one of the most common things that I end up getting called to see. They usually present in isolation as hyperpigmented or orangey pink flat nodules or plaques. One of the ways that you can distinguish them from other forms of newborn lesions is to rub them. This is called Darier's sign. When you rub the lesion, it will develop a wheal around it. Because these are mast cells, the friction is actually triggering degranulation and histamine release. And so you will see a wheal develop around them 2 to 3 minutes later. And so this can be a helpful clue and avoid having to have the patient biopsied. In isolation, they tend to be asymptomatic. They will go away with time. Where we get more concerned is when the patient has multiple lesions, as evidenced by these individuals here, where we're looking perhaps with more pigmented lesions, a greater number, usually over the torso. This is urticaria pigmentosa. In few numbers, in isolation, not worrisome. When there are extensive numbers, we are more concerned because you can certainly generate a systemic degranulation or systemic release of histamine if all of the lesions degranulate, such as with bee stings or things like that. And so we will start these patients on a regimen if they are active of antihistamines or mast cell stabilizers, and very often we will also provide an EpiPen in case of any anaphylactic type reactions, which again are rare but can happen. In addition, we want to check a CBC and tryptase in these patients as well to rule out systemic mastocytoses, which would be, again, quite rare. So you get a call from a patient's mother that after a scrape, there was a rash that developed on the site of the wound, and there's a concern perhaps for infection. The patient comes in, and you can see here that there is a red vesiculating plaque that's developed. One of your clues probably will be that the lesion is itchy rather than painful. But the other clue is going to be the shape. Clearly here we have a rectangle, and anything that's not really circular or ovoid is probably not being generated by the body itself. It's what we call an outside job. So some external force creating a reaction. And in this case, with the degree of vesiculation and itch, you would think about a contact dermatitis. And we see this not infrequently after the use of bacitracin or neomycin. And in fact, up to 15% of Americans will develop a contact allergy to one of these two agents. And this actually is increased when you continue to use it on open wounds, and so not a great topical agent for chronic ulcers or to prevent infection of chronic open wounds, as you can induce this process. Sometimes it does require a little bit of detective work to get a sense for what your allergen is. Patient on the left, probably the topical antibiotic. Patient on the right, clearly more likely the adhesive. We can actually tease out the agents if you're not quite sure what someone is reacting to through the use of patch testing, where we actually apply the topical ingredient to the skin through special stickers, and then we have them stay on the skin for 48 hours, remove them, and then assess the patient. We can then identify the specific fragrance or adhesive agent, et cetera, that the person is reacting to, and then generate a list of topicals or items that do or do not have that agent, so that the patient can then go forward and choose accordingly. Now, children with a history of atopic dermatitis are more prone to develop contact hypersensitivity. Most studies suggest that when this happens, it's to a fixed and repeated offender group, mostly nickel, wool alcohols. We've seen neomycin again, but a variety that I've listed here. The highest rate of sensitization occurs from age 0 to 3. And the main one that I think we have to think about in children with atopy is lanolin, because this is actually a common ingredient in some moisturizers, particularly the ones that are based out of Europe. It's a wool alcohol, and it can actually generate an allergic contact dermatitis, which makes it very difficult to tease out, is the eczema flaring or have we induced a lanolin hypersensitivity? And so in general, we tend to move away from moisturizers that contain that ingredient. Another flavor of contact dermatitis is irritant contact dermatitis. This, instead of being an immune-mediated reaction like poison ivy, is one where you have created irritation, thinning, drying out of the skin based on what it is that you're exposing the skin to. So whereas with allergy, you will only see this develop in predisposed individuals, with irritant contact dermatitis, anyone put under the same circumstances will eventually develop an irritant dermatitis. The only difference is when. And so we see this a lot with frequent hand washers, individuals who work with corrosive substances. The key is to remove the offending agent and to try to restore the epidermal barrier through good emollient use, really drying the hands well after hand washing, moisturizing afterwards, limiting hand washing using alcohol-based hand sanitizers, assuming there aren't fissures in the skin, and then certainly topical steroids can help to reduce some of the inflammation as well. One of the most, I think, perplexing set of rashes to deal with are the diaper rashes, because they occur in the same area, can look very, very similar, and will have very subtle differences that are helpful when you're able to detect them, but frustrating when you're not. And so the differential is quite long, and we'll go through the ones that are the most common. The first one here you can see is very much limited to the diaper region. It's fairly well demarcated. It looks red and irritated. If you were to examine the skin folds of this child, you would probably see relative sparing, meaning that the rash is either absent or diminished in the areas of the folds. And that's a clue that you're dealing with an irritant contact dermatitis. So this is a child who's probably sensitive, and then the wet diaper or prolonged contact with the wet diaper or stool can actually create irritation and inflammation of the skin. And we see this particularly in children who are predisposed to eczema already. And so more frequent changing of the diapers can help, as can a really good, aggressive barrier cream to the skin with every diaper change, just to put a layer in between the irritating substance and the easily irritated skin. Now, I want you to pay close attention to the color of this contact dermatitis here, because what you'll see in the next slide is a very different picture. So we have a dull or maybe medium colored red. And the other thing you're seeing is, again, very well demarcated, no lesions at the periphery. The rash starts and stops quite abruptly. Whereas with this picture here, you see that the rash is much deeper, more intensely red. It's a little bit glossier, and then you see there are all of these surrounding papules and maybe even pustules at the periphery. Sometimes you'll hear us use this term beefy red because it's the color of ground beef, a very intense erythema. And these two should be a sign of candidal dermatitis. So again, treated in a similar way in terms of keeping the skin from being irritated and wet, but also now applying a topical anti-yeast agent. Now, not all things that are satellite are candida. You can see again the color now has gone dull again, not as bright, very light pink, and you do have these peripheral lesions, but they're not red, they're not papules or real pustules in an inflammatory sense. What you're seeing instead are these scaly papules, and this is actually psoriasis, and what you're seeing is the scale being diminished in areas of warmth and moisture, which is commonly seen with a form of psoriasis called inverse psoriasis. And really when you get out of that zone is where you start to see the more characteristic scaly papules that we expect to see with psoriasis. This is a fairly rare thing. We don't usually see infants with psoriasis, but it can happen, and so good to familiarize yourself with. Other things can be scaly, though, in this region. You can see here this child has a very chapped-looking eruption. The clue, though, is that there's also balanitis and inflammation around the mucosal skin as well. And so this is an example of acrodermatitis enteropathica, and so nutritional deficiency here that needs to be corrected. You may also see lesions around the mouth, other orifices, and so good catch and then easily corrected. If you see that these papules, however, are occurring in a scattered fashion, they are palpable, you're seeing petechiae arise with them, that's a little bit more worrisome, and we start thinking about more rare things like histiocytoses, particularly Langerhans cell histiocytosis. Here's another example, really in the folds, but you can see the scattered petechiae under the pressure sites of the elastic band or the waistband. And so something like this, or really any rash that's not getting better with a good 2 to 3 weeks of care, should be referred. We can certainly evaluate and biopsy if necessary. This child has a rash in the diaper area that's confined to the perianal skin, very bright red, erosive. It may not be this pronounced, and the child may actually present with constipation. And this is a perianal streptococcal cellulitis. And the name's a little bit misleading because now we're realizing that Staph aureus plays a significant role in some of these infections as well. And so very often we will swab them to see which of the two agents are at play on presentation. But this can be a very painful erosive eruption, which leads to withholding in these children and then the presentation in constipation. And so we will treat the underlying infection, but then also recommend stool softeners to help get through this process. Now, this patient has well-demarcated xerotic lichenified plaques of the popliteal fossa. On the patient on the left, you see the erythema more prominently. When there is baseline pigmentation, you may not see the erythema as much, and instead you may see hyperpigmentation. But the distribution and the dryness, and then you can see the erosions from scratching, are really what help you to recognize this as eczema. When eczema is followed by a strong family history of eczema, including eczema into adulthood, asthma, allergic rhinitis, we think about it as being a subtype of eczema called atopic dermatitis, but otherwise eczema. Children who are atopic will tend to have a harder time getting rid of their eczema, whereas children who have just run-of-the-mill eczema tend to outgrow it in a couple of years. Infantile eczema is an exception to the flexural rule that we tell everyone about. In infants up until age 2, you will see flexural involvement instead, which is more reminiscent of psoriasis, but it really is eczema. So elbows, knees, dorsal ankles, and then a very significant component around the mouth, which is exacerbated by the drooling that we see with teething and such. And so really aggressive emollient use, topical steroids when inflamed, controlling the itch, all very, very helpful. We're also seeing that children who are atopic have increased sensitivity to external irritants and allergens, but also to bacteria that normally live on our skin, so being colonized rather than infected. And it's thought that these organisms are inflammatory, and this drives the eczema to being either more severe or potentially recalcitrant to previously effective therapies. And so one of the ways that we used to deal with this was through short courses of systemic antibiotics. But we're realizing now that actually intermittent chronic dilute bleach bathing is actually quite effective as well, and does not carry the risks of recurrent, repeated antibiotic use. Fortunately, atopics do not seem to have an increased susceptibility to MRSA infection, and so if you do see someone who is truly super infected, treating first for MSSA or culturing may be the better way to go. But if you approach bleach baths, we usually tell parents to look to do this once or twice a week. For a full tub, you would use half a cup of household bleach. For half a tub, you would use a quarter cup, and it would be a capful in a baby tub. And soaking is 5 to 10 minutes. I usually recommend that people rinse off because a lot of times the dried, even low concentration of bleach on the skin can induce itch. Some people will say to leave it on the skin and not rinse, let it air dry. It may be more efficacious. The bleach can last longer. You can try both and see what works, or tell patients to try parents to not rinse, and if that works, great, and if it doesn't, then certainly go back to rinsing. But soaking for 5 to 10 minutes twice a week really is often sufficient. You can also swab the nose to see if there's nasal carriage, and if so, go down that decolonization regimen with topical mupirocin. But certainly this is an easy approach, albeit a strange one to explain for the first time. I liken it to swimming in a chlorinated swimming pool, and sometimes that gets me a little further than implying that children should be soaked in corrosive bleach. So again, very dilute, probably about the same quality as being in a chlorinated swimming pool. Now, we also call eczema the itch that rashes, and so it's very important to address the underlying pruritus. There are a number of different medications that can be used. In general, sedating antihistamines tend to be more efficacious than non-sedating antihistamines, and for school-age children, we will recommend using the non-sedating agents during the day and then reserving, if needed, any sedating agents for a half hour before bed. Another question I get asked almost always with new patients is whether or not the child should be tested for food allergies. And actually, we're seeing less and less relevance to this now, and we really want to make sure that we only send for food allergy testing in children where there is a clear history of a specific food leading to a reaction, or if the child is truly, truly recalcitrant to appropriate or more aggressive therapies. In general, when children are food allergic, in the setting of atopic dermatitis, we think about milk, eggs, soy, wheat, peanuts, sometimes fish. But general testing without really an attempt to qualify what the offending agent is now actually not something we recommend. Fortunately, the risk of significant reactivity to food diminishes as the child gets older, and so that is reassuring for some patients. And certainly there are programs, mostly academic, that will desensitize children to certain foods, and so that may be something that can be looked into as well. But unless a careful dietary history suggests a specific food trigger, we usually don't restrict diet in children, particularly in children greater than age 5. Now, all children with eczema or atopic dermatitis really will get the same counseling in terms of dry skin management. We recommend short showers or baths, no more than 5 or 10 minutes, using warm rather than hot water, and then frequent emollient use. Creams tend to be more efficacious than lotions. They're a little thicker. They have more of an oil content to them. If you are going to do something like a Vaseline, you want to make sure you're putting it on damp skin. Putting an ointment-based emollient on dry skin is just creating a barrier. So similar to a diaper cream, you're not actually absorbing the same water content as you would expect. But putting it on damp skin after a bath or a shower will actually trap some of that moisture into the skin, making it more efficacious as an emollient. Now, there are some complications that we really want to watch for with children who have atopic dermatitis or eczema. The most worrisome is the one that's featured here. You can see the distribution of these lesions is really concentrated over the popliteal fossa, and so we know that the child's initial eruption was probably atopic dermatitis, but we have a secondary infection here. And so there are a number of little papules and pustules that have developed, but the main lesion that sticks out, that I find to be the most helpful, are these eroded papules. They almost look like little volcano craters, and up close you can see them here. So these punched out erosions should really raise concern for eczema herpeticum. So HSV superinfection of eczematous lesions, but really of any dermatitis in general. The other name for eczema herpeticum is Kaposi's varicella-form eruption, and that implies that it can be a superinfection of really any skin process that impacts the integrity of the barrier of the skin. More often we see it with eczema, however. So here you can see little pustules. What happens with infectious vesicles is that eventually they recruit neutrophils and they become pustules. And so certainly if you saw these, it might be confusing for a staph process, which is far more common. But with these punched out lesions, really think about eczema herpeticum. Now the child's scratching, and so that's part of the reason why you're seeing erosions rather than these beautiful clustered little vesicles. You also don't see the clustering because the virus is taking hold of all defective skin as opposed to coming up through a nerve root where the lesions tend to cluster with a base of erythema. And so the additional complications that we worry about is bacterial superinfection, fluid loss, and then viremia if extensive. Like this child here clearly has far more involvement than our other patient does, but you can see these very discrete punched out erosions throughout, becoming quite confluent on the worst areas here. So I would be more worried about this child. In addition, you can see the periocular involvement here. This warrants an ophthalmology consult. Any eyelid involvement or any concern for ocular involvement, you really want to get ophthalmology to rule out a herpetic keratitis. Unfortunately, children touch faces a lot, and one of the complications that we can see from that is a child inoculating on perhaps a parent or a caregiver's labial HSV, and so sometimes you will see herpetic whitlow actually in infants and children, or if they've touched their own face with eczema herpeticum. But again, you can appreciate the little vesicles. The grouping is harder to see on a acral surface. What you might see instead is this scalloped or nicely rounded edge that picks up the circular sides of these lesions. How do we approach eczema herpeticum? For real limited involvement, you can do a systemic oral antiviral. For more progressive involvement or for any concerns of ability to care at home, any concerns for systemic viremia, any concerns about the ability to take and maintain good PO and hydration, we would admit and give IV antiviral therapy. Certainly if there's any secondary bacterial infection, you want to treat for that, and I will swab people if I have any concerns that there's more than one process going on. These eroded lesions can be quite painful, so keeping that in mind, and then also controlling the itch so that the process doesn't continue to spread while you're trying to get control. Once you are moving in the right direction, sometimes after 24 hours of antiviral therapy, we will recommend starting to actually treat the underlying process so as to try to reduce inflammation and possible spread. Now, over here, we're looking at the antecubital fossa. Same kind of idea. You're seeing these tiny little vesicles, but they are very, very fragile. And you're not seeing that raised crater-like border. What you're seeing instead are these erosions. And you're seeing this very nice yellow, almost honey-colored crusting here. And this is an example of bullous impetigo. And so the idea is that your staph is actually producing a toxin that acts locally to where the staph is present. And that toxin cleaves a protein in the skin that produces little vesicles or erosions here that are quite fragile. More classically, you'll just see secondary impetiginization, where the excoriated or rubbed skin has now become yellow crusted. And so if limited, you can treat with a topical antibiotic, or if widespread, then certainly a superficial one, again, keeping in mind your community rates of resistance versus MSSA. I will culture anything that is open, acutely open, or purulent. Now this photo here, I don't think anyone would miss. We have a ring with central clearing. You would see this child in the office and immediately think erythema migrans or Lyme disease. But what's important to keep in mind is actually that ring with central clearing that we teach people about is actually only present in fewer than 10% of cases. And instead what we see more often is this homogeneous erythema, very well demarcated. And so your first thought might be cellulitis, but the really sharp margins should move you away from that. And usually we're dealing with a funny place to torso rather than, let's say, leg or hand. Sometimes you'll get a true target in central prominence, ring of sparing, and then another ring around that. And so there are a variety of ways that erythema migrans can present, but it is some of the most frequent, earliest presenting features of Lyme disease. We usually see it within a month of detaching of the tick. And in addition to that homogeneous erythema, you can see prominent erythema, so a red patch with a dark red center, or you can even see purpura or even vesiculation centrally, depending on how exuberant of a response you had to that tick bite. And here's a person who had a very strong tick bite reaction. You can see here's his erythema, that homogeneous erythema. Here's the more prominent central redness, and now in the center you're having this pseudovesiculation that's forming, and you can see where the tick was once attached. You have that little hemorrhagic crusted papule. Where things can be tricky sometimes in distinguishing erythema migrans from bacterial infections like cellulitis is when the organism induces a neuritis. And so you will often see patients complaining of pain in these areas. However, you may also see itch. And if you see itch, that's a sign that you're not dealing with cellulitis. In addition, this is a treponemal infection, and so similar to syphilis, when you start treating, if you're on the right track and those organisms are lysing and releasing cytokines, you may develop a systemic inflammatory response called a Jarisch-Herxheimer reaction. So the patient may develop fever, the rash may become more prominent, carry on with your clinical suspicion. Now, the complications of erythema migrans you're all very familiar with. We tend to favor clinical suspicion in terms of treatment because of the very high rate of false negative testing that can arise when you test someone early. And so certainly treating and then testing later, or repeating if you're concerned about a false negative, is not unreasonable. And the treatment, again, just a review here. Under 8, we want to avoid tetracyclines. If you are a penicillin allergic, cefuroxime, erythromycin, clarithromycin are alternatives. And if you're really not sure, staph, strep, or Borrelia, amoxicillin clavulanate will cover all 3. It does not cover the stowaway, anaplasmosis, et cetera, that may be present in certain areas. A final word, this is a patient with a large homogeneous erythematous plaque. But if you look carefully, you can see there are these little baby plaques as well. And so this is disseminated Lyme. This is his back. And the point here is that the initial lesion determines the morphology of the other smaller lesions or the additional lesions that arise. And so in this individual, we had a plaque, and you have multiple homogeneous red patches and plaques. If they were rings, you would see all rings. But that is a good example of disseminated ECM. Here's a woman who was admitted for cellulitis. You can see that prominent central erythema. The clue here was her back. Usually we don't expect to see cellulitis in the back. We don't expect it to be so well demarcated. And if you look here, you can see she has dermatographism, so these linear streaks. It's a sign that she's been scratching. So we asked her, and she said she was incredibly itchy, and that led us down the pathway to securing the right diagnosis. Talked about the Jarisch-Herxheimer reaction already. If you have a tick bite situation, there's certainly an opportunity to Lyme prophylax. If you know that the tick has been attached for more than 24 hours but less than 72, this is an option. If the child is over 8, then it's very simple, doxycycline once. If the child is under 8, I almost feel like you might as well treat for Lyme because the prophylaxis is not too much better. In tick endemic areas, you may want to think about DEET application before going out into wooded or at-risk zones, and certainly very good tick checks afterwards may help to diminish the risk of this. One of the other most common things I see in the office are molluscum. This is from the pox virus in children, very, very common. Usually we stop seeing it after age 12. It may recrudesce in an adult form, but in this case, if you see it in an adult, it is an STD or associated with immunodeficiency until proven otherwise, and so you want to make sure to get those folks worked up. But in childhood, extremely common, spread through skin-to-skin contact or through fomites or from scratching. This is a disaster in kids who have widespread eczema. Just like our eczema herpeticum, you can get eczema molluscum, where the children just inoculate huge numbers of these lesions. And so we think about them as dome-shaped, skin-colored, or pink papules with umbilication, but not all of them will actually be umbilicated, and this is a great example of that. If you look hard enough, you will find a number that do have the umbilication if you have any concern that that's not quite what you're dealing with. But very few things will present with these beautiful little golf ball-shaped papules. The other thing you might see in addition or instead of umbilication is a little keratotic plug in the center. That's usually a sign that the lesion is going away. But in addition to just seeing the lesions or seeing them spread, you may also see patchy erythema around them. It almost will look like a patch of eczema around the molluscum. This is actually a good sign. It's molluscum dermatitis. It's a sign that the body is actually generating an immune response to try to clear the virus and to clear the papules. And so doesn't need to be treated. So here's an example of that molluscum dermatitis. Again, eczematous eruption, well demarcated. Here are your umbilicated papules throughout or peripheral. Here's another little patch of molluscum dermatitis, and you know also that this lesion is resolving because now you have that little keratotic core that's being expelled. So I wouldn't actually treat this lesion. It's already being treated. Now, when patients come in with a small number of lesions, it's fine to just monitor and watch them resolve automatically. The reason why we often will discuss treatment is if they are in cosmetically sensitive areas to allow the child to go back to school, if we know there's underlying pruritus that would lead to inoculation, or if they're increasing in number. The two main treatments that we utilize, which are currently off-label but widespread use and known to be very safe, is cantharidin and cantharidin plus. There are topical agents that are widely reported in the literature. I would advise caution in using Aldara and tretinoin because they can be quite irritating to the surrounding skin, and so you can actually induce your own propagation of these lesions. If the parents are very meticulous about just putting the agent on the molluscum, you may have a better chance, but usually this gets spread diffusely, and so you can have the molluscum move into areas of manipulated skin integrity. I try to avoid curettage and cryotherapy. It never goes over well for these younger children. They're traumatized, and almost always it's not just a single lesion. There are many, and so to have to go through all of these or go through them on multiple lesions just isn't something that I'm excited about doing. There are also reports of oral cimetidine, which, as you know, is a treatment that we utilize more for GERD, but has been shown in some individuals to be quite effective when we're looking at dozens or hundreds of lesions. I find that it either works or it doesn't. You either seem to have an immune profile that responds to it or not at all. But going back to cantharidin, it is an extract that originated in its discovery from the blister beetle, and it induces blistering where you put it. And so it's very, very important that you just put it where you need it. I use the back of a wooden Q-tip to really just make this pinpoint application. The fabric part just puts too much on, and you'll get blistering truly wherever it touches. And so the child will develop a little blister. It's painless in the office, but there may be some discomfort associated with the blister. We usually do Vaseline and a Band-Aid until it heals, and we want to counsel them to wash it off. Usually 4 to 6 hours later, if the child has really recalcitrant lesions, or sometimes when I use this actually for plantar warts, I'll have them leave it on overnight. Brief word about melanoma. We really want to make sure that we advocate for good sun protection in childhood. You get about 80% of your lifetime sun exposure before you turn 18, and we know that the number of blistering sunburns or sunburns in isolation that a person develops will double or even higher rate of increase of their melanoma. The other group that we worry about are the first-degree family members with melanoma, and so we really want to watch nevi. We want to make sure that children get into good sun protective habits early, and then when you evaluate nevi, you want to use your ABCD criteria. We have added an E for evolution, so any mole that's changing size, shape, symptoms, etc., we want to take a look at those lesions. The moles that don't follow these rules are the congenital melanocytic nevi. They are the ones that you'll get the story they're present at birth or shortly thereafter. They've been present forever, but they often are irregular in size and color and shape, but they're stable. That's the most important thing, is to make sure that you're following them and it looks the same every time you see the child. We categorize them based on size, and actually there's a typo here. Small is less than 1.5 centimeters. Medium is between 1.5 centimeters and 20 centimeters. We don't worry about these as much. The risk of conversion is thought to be around the same as a regular nevus. When they do convert, you'll see a change in shape. There's something that happens most often at the periphery. Here's an example here, 1 centimeter size. You can see the borders are a little bit lighter, the center is a little darker, but we know from following this nevus and from the history that this has been present and stable forever. This is a medium congenital nevus. These will often look like cafe au lait macules when the child is born, and then over time, they'll get a little darker, a little thicker. They may grow hair. Same thing, we'll watch for any change at the periphery. Now, the exception to all of this is the very rare subtype of large or giant congenital melanocytic nevi, and these are defined as being greater than 20 centimeters. Some people are thinking we should recategorize to 40, but increased risk of melanoma, usually when these convert, they convert in childhood before puberty, whereas the small and mediums, again, because they are behaving more like regular moles, will convert if they convert in adulthood. These also, when they develop trouble, it's often under the surface, so very important to palpate these lesions. And then here's an example here, very extensive, but this child also has small and medium number of satellite lesions, which also increases the risk. So for all of these, just regular follow-up. If you're comfortable following the moles, by all means. If not, they can come in and see us. We can share the patient. We don't really recommend excision of small or medium congenital nevi unless there's a cosmetic concern. And then under those circumstances, probably better to do it before the child starts school. It needs to be really weighed with the risk of general anesthesia. For the larger lesions, we really tend to monitor. There's a lot of controversy about how to manage these. Now, newborns will develop rashes that are often worrisome when we see them, because we associate newborn rashes often with significant infections, but there are two in particular that I want to review that are very benign. This baby here would present perhaps at a week of age with these erythematous macules or papules. Maybe you'll even see tiny little pustules, and this should raise a flag for erythema toxicum neonatorum. Baby's well, mom is well. It's a self-limited course, and it tends to spare the palms and soles. If you were to scrape this and look at it under the microscope, you'd see eosinophils. That's a great clue. I usually swab pustules no matter what, just to be certain, make sure it's not candida. But again, these are well children, and you'll see that big, bright kind of range of erythema around it. Another version, which also raises some concern, is the one that we see right at birth or shortly thereafter. And these children are born with pustules or hyperpigmented macules, or these little collarettes of scale that imply that there once was a pustule that's then been eroded. And this is transient neonatal pustular melanosis, so exactly what it sounds like. Self-limited in the very, very early period, pustules, and then they heal with hyperpigmented macules. And so very more atypical, I think, than the erythema toxicum, more often seen in darker skin types. If you were to stain this, you would see neutrophils, but usually they are fairly rapidly self-limited. In older children, I pay more attention to pustules. This is probably 12 to 18-month-old who comes in with a number of pustules limited only to the acral skin, incredibly itchy, no affected family members. This is acropustulosis of infancy. We see it somewhere between birth and 2 years of age, usually in the 12 to 18-month range. You'll see pinpoint papules and then turn to pustules. Rarely you'll see it on the face. Very, very itchy, but self-limited. Goes away with antihistamines and topical steroids. Nonetheless, I will still scrape these children for scabies. Sometimes the child is the first presenting sign before anyone else in the family is affected. And this is scabies. So you can see very difficult sometimes to tell the difference. This child also had very concentrated acral involvement, a little bit more vesicular than pustular, and that was, I think, what was more of the clue that we were working with something else. But both of these patients do warrant a skin scraping to look for scabetic mites, more rarely, more often eggs or fecal matter. Now, these photos here are tinea. You will see a child presenting with patches of scale or areas of alopecia. One of the clues with the round alopecia that should distinguish it from alopecia areata is you'll have all these little tiny black dots, which represent infected hairs that have become weakened by the fungus and broken off. I will always palpate for occipital lymphadenopathy. I think that's one of the nice helpful signs between seborrheic dermatitis and tinea. Everyone tends to get scraped. I'll look at it under the microscope, or I'll send it to the lab. And if it's tinea, you really want to treat with an oral medication. In the U.S., T-Tonsurans represents the overwhelming majority, but a number of other agents have been described as well. All dermatophytes, so if you scrape and look under the microscope, you will see branched and septate hyphae representing those organisms. This is a KOH prep. Now, we do recommend microsized griseofulvin now rather than regular. It's more effective. You can also use the ultra microsized form, but the dosing, as you can see, is quite different from what you may remember from regular griseofulvin. Absorption is enhanced with a fatty meal, and so we do recommend taking it after eating. Another version of tinea that I'm less worried about, but patients are much more worried about, is tinea versicolor. Now you are seeing these macules that are often leaving patches of hypopigmentation behind. This is from malassezia. The malassezia produces azelaic acid. The azelaic acid bleaches the skin. One of the ways that you can test your theory is take a gloved finger, rub the lesion, rub the skin around it. The skin usually stays the same, but the lesion will develop a very fine powdery scale, and that is what you would look for under the microscope. We call this spaghetti and meatballs. A lot of bad food references in dermatology. I apologize, but you can see here we have our hyphae, and then these spores are supposed to be the meatballs. One of the clues, tinea versicolor loves the central back, central chest. It may start to migrate into the hairline. Even after you've appropriately treated it, there may still be some dyspigmentation. You just have to reassure your patients and counsel them that it doesn't mean that the rash is still present or active. It's just going to take some time for the body to reproduce that pigmentation. Main thing on the differential, rare but perplexing when it happens, is confluent and reticulated papillomatosis, or CARP. This will affect almost exclusively teenage women, and they will develop it on the sternum, the inframammary region. It will look just like your tinea versicolor, the hyperpigmented version, but it's not responding to the appropriate therapy that you've tried and the patient has diligently worked with. One of the clues is that this is actually raised, more raised than your tinea versicolor. And you can see here with the side lighting, again, you're lighting here and you're creating a shadow. It almost looks like acanthosis nigricans. It's thick, it's a little velvety, 100 milligrams of minocycline BID for 2 weeks, and it all goes away, and the patient's very, very happy. Briefly, just to touch upon vascular lesions before we end, these are what I get called to the newborn nursery for the most. And we'll go through hemangiomas and port wine stains. So hemangiomas come into two categories, infantile and congenital. The infantile are usually not present in any real way at birth. They evolve over the course of a year, and then they start to regress. They can be superficial, which usually looks red, or they can be deep, which usually looks more blue with surface telangiectasia or maybe a superficial component associated with it. Whereas congenital hemangiomas are present at birth, and they have two different types. The kind that are present and then rapidly resolve before your eyes, usually gone within a year, and then there's the non-involuting congenital type, which are here to stay and probably will require surgical intervention. Hemangiomas, we can do the watchful waiting if they're small and not problematic, but I want to show you a couple of sites that really should make you take pause because perhaps we're worried about underlying involvement. Like with the airway here, any beard distribution, neck, big lower facial involvement, it warrants endoscopic evaluation or imaging to be certain that you don't have a vascular lesion inside that may rapidly proliferate. Ulcerated lesions as well really do require rapid assessment. Anything on a cartilage bearing site, nose, ears, the vermilion of the lip even, any cosmetic area that if deformed will not look normal when the lesion resolves, it's very important to have early assessment and intervention. This lesion on the lateral aspect of the eye I'm not as worried about. It's not obstructing vision, but if it were to obstruct vision, then that's definitely an indication for rapid intervention. These represent deep hemangiomas. Again, you can appreciate maybe a little bit of telangiectasia. Here you can appreciate the blue quality. This is a mixed hemangioma. You see the deep component, and then there's a superficial component on top of that. And then here's my rapidly involuting. You can see this little guy right after birth. We were called to see this, and then this is him a month later. So very, very quick, spontaneous resolution. So again, active non-intervention for a significant proportion if they're small and not in cosmetically burdensome areas and they're behaving. You can also do topical intralesional or systemic corticosteroids, but the new big thing really is propranolol for rapid improvement and fewer side effects. We're also now starting to use topical timolol for superficial lesions, as well. You can also, in conjunction, use laser therapy, and then we can excise any non-involuted congenital hemangiomas or any of the fibrofatty tissue that results after these start to involute. And then this is just a nice little article that goes through the efficacy and safety profile of topical timolol. Again, you can see this is not a big bulbous hemangioma. This is just a barely raised plaque, but quite nice response. Things to keep in mind with the article reviews, it is 4 to 10 times more potent than propranolol, and so we want to make sure that we're using a finite amount. It's very important to counsel parents 1 to 2 drops per application. We monitor for the same things that we monitor for with propranolol, and we think about this more so in areas where there's going to be increased absorption, so ulcerated areas, mucosa, thin skin sites. But again, this article really suggested that all children seemed to tolerate it well. In their study, there was one child who developed a sleep disturbance that was not necessarily related to the medication, but reported and otherwise well tolerated. Now, the cousin to the hemangioma is the nevus flammeus, or port wine stain. This, instead of being a proliferation, is actually a malformation. You have these large dilated vessels. They are present at birth. They darken and proliferate over time. And so now we actually do recommend for cosmetically sensitive areas early laser treatment to try to reduce the burden of the vasculature before these thicken and darken over time. So here's an example of an infant very early on. These will blanch to a certain extent. But this is what we're trying to avoid. So untreated, they can thicken, become very mammillated. The other thing I would worry about this person here is that we're looking at a lesion that's in the V1 distribution. That should raise concerns for Sturge-Weber and workup, because there can be some CNS involvement as well. So I call these vascular plus. So any of these phenomenon or situations, I warrant additional workup. So diffuse neonatal hemangiomatosis, so multiple hemangiomas, V1, V2 distribution, that make you think of Sturge-Weber, Klippel-Trenaunay, where you have extensive involvement of an extremity, usually leg, and then Kasabach-Merritt, rapidly growing and proliferating lesion. So here's an example of diffuse. These look really tiny, they look innocuous. The main concern is that you may have them internally as well. And so the big organ that we worry about is the liver. There can be consequences if these are larger lesions and they're shunting blood flow. And so usually we start with an abdominal ultrasound with Doppler studies, and then you may do some additional imaging and workup as listed below, depending on the lesion. Again, V1, V2, think about Sturge-Weber, sent to ophthalmology, neurology, CNS imaging. Extremity involvement, like the arm in that first patient on the leg, we think about Klippel-Trenaunay. These children are at risk for lymphatic issues, soft tissue hyperplasia, and so we really approach these with compression and close monitoring. Kasabach-Merritt phenomenon, very, very rare. It's a hemangioma accompanied with thrombocytopenia due to a consumptive coagulopathy that is induced by this larger, rapidly growing hemangioma sequestering your platelets. So we watch these children very closely. We will get a CBC, a coag panel, and very often we will biopsy to see if there is a particular histologic feature that's more associated with this type of process. So to summarize, I hope this has been a good review of things that you may see often in the office or that represent questions that may come up for you clinically, and offer some pearls and solutions for how to manage them, diagnose them, and perhaps